Jeremy and the crew here for inviting me. Complications is where I shine, so when Jeremy asked me to do this, I was like, yep, I got a lot of cases. So cervical TDR was not the right choice, I think was the name of the topic here. No relevant conflicts of interest. So this is a 47-year-old male who presented to me with neck pain and left arm radicular symptoms following the C6 and C7 nerve root distribution. He'd had this for a while. He had treated with all the conservative means you can think of, physical therapy, multiple injections, had in New York City about 15 opinions already. So he came in, he saw me, and one of the first things he said, I don't want a fusion. So, we got an MRI. We looked at his MRI, and he has, as you can see on the left, midline cut. Not very impressive, disc bulging, loss of disc height, maybe a little bit of, focal kyphosis at 5'6", but otherwise fairly neutral. And then if you look at the left paracentral cut right over here, you can see he had more of a foraminal disc fragment at C5'6" and a little less of a fragment at C6'7". And so these are the axial cuts, C5'6" on the left, C6'7". 6'7" was a soft call, but he had neurologic symptoms that were fairly typical of a C7 nerve root issue. So, given what I showed you guys, I'd like to just poll the audience. How many people would do an ACDF, a two-level ACDF here? Okay, we have, oh, good. I'm in good company. And how many would do a TDR? And maybe the rest of you are smart and wouldn't even operate on him. And, so this midline cut didn't look too impressive, but he really had bad radicular symptoms. So would anybody change their mind if this guy, sorry, I guess, this is what I did, two-level TDR. This guy happens to be a physician who I see fairly regularly, in the hospital. And so, this was also a setup like Murray was talking about. You don't want to get jinxed. And, I kind of normally maybe convinced him to do an ACDF, but he seemed very knowledgeable. He had a bunch of opinions, very active. So we did a two-level TDR using the Mobi-C. And these were the intra-op pictures. Didn't love the way that the end plates were already tilting on the AP, but that sometimes I find happens with the Mobi-C implant. And it's not really my implant of choice. So he did great for 2 weeks, loved me, had my cell phone number, would keep texting me on how great he's feeling. And then I got a text, late evening, my pain is back. And, when it's a colleague and somebody you see regularly, you can't get away from it. And so this is sort of where it started. So initially, put him on steroids. He felt a little better. Then his pain came back, and then I got an MRI on him. So the top two are the post-arthroplasty axial cuts, C5'6" on the left, C6'7" on the right. I thought it looked reasonable. I, reassured him maybe it's just radiculitis, start, gentle PT, and let's see what happens. X-rays looked fine. A week later, started texting me more, pain not getting better. So then I got this CAT scan. Sagittal looks crappy, wasn't my proudest work, but if you look at, that C5'6" level, more kyphosis there, maybe the inferior end plate's a little bit too posterior. On the coronal, the fill looked pretty good. I think we had good sort of uncus to uncus apposition. I didn't over-distract him. The size seemed okay. So, his symptoms continued, and these were the foraminal cuts. I like to get oblique cuts on these because I think they're very helpful to examine the foramen. Nothing looked grossly abnormal, but he continued to have left-sided symptoms. So just pivoting, we're not going to, I don't want to make this too dogmatic, but, criteria for success for ACDF. We'll get back to the case in a second. So you got to relieve symptoms of radiculopathy or myelopathy, and outcomes should be at least better or the same as ACDF. And then avoid complications associated with the ACDF, which we worry about, revision surgery, adjacent segment surgery, non-unions, things like that. And then it should be safe and cost-effective. That's why we want this procedure. And there was a great symposium yesterday where I think a lot of the panelists went over all these issues. So again, in the interest of time, I'm going to skip over the contraindications to arthroplasties. But again, prerequisites for a successful outcome is you want to restore and maintain cervical alignment, establish normal kinematics, and then promote anterior and posterior column sharing. So if somebody's facets are really trashed and they're loading their facets, they're not going to do well with arthroplasty. And then you want to minimize picking an implant that might cause debris or other complications. So this is a whole host of complications that can happen with an arthroplasty. And some of them, you can also get with an ACDF, and some are technical, but HO, for example, segmental kyphosis, hypermobility, implant migration, subsidence, allergic reactions, on and on. So why do we feel like this is a better option than ACDF? Because, we do have a lot of high-grade literature, high-level literature that says this, and I think Dr. Sasso yesterday presented some of that data. But there's clearly failures. This is not utopia, and I think patient selection is the most important aspect of your results. So this was a good study that I found. This was from the Rush group. They did a retrospective review of 169 patients and a systematic review of about 4,000 patients, and what they saw was 4% failure rate in the arthroplasty cohort. So and this was only like a short-term 2-year, follow-up. So, arthroplasty is not utopia. Again, patient selection is key, and they further subdivided the failures into these 6 modes. I think, we don't want to get into the weeds of all the different modes, but I think what you want to do is come up with a rubric or an algorithm of how, if you get a failure, are you going to fix this anteriorly or posteriorly? So this is also from that paper. I found it to be a little too complex, so I found an easier international study that I'm going to talk about. And this group looked at 21 revisions. Majority of them were revised anteriorly, but there were 3 posterior revisions. They had 2 pseudoarthroses from a revision fusion, and both of those pseudoarthroses happened in the anterior cohort, which kind of makes sense because if you're revising a pseudoarthrosis from an ACDF, most of us would do posterior fixation and fusion because it has a much higher fusion rate. And their rubric was a little bit simpler. So again, to decide whether to go anterior or posterior, the major impact for that is, do you need to remove the arthroplasty device? Is it causing any kind of compression, neurologic problems? And so ended up having a 2-level fusion, and he did well after that. Well, thank you.